Good evening. We are starting today's presentations. I welcome Madam Lalanta Senaratne for our presentations as usual today. And today's presenter is Dr. Sandamali Samarasinghe, registrar from the Guns and Roses batch. And she will be presenting a case of a child with chronic abdominal pain. And without further ado, I would like to invite Dr. Sandamali to present. Thank you.
Thank you, Dr. Prabhat. Good afternoon, my dear madam and my dear friends. I will talk about this child whom I wanted to share the story with you. I came across in my pediatric appointment. Am I clear? Am I clear?
Yes.
Can you hear me? Okay.
We can.
Okay, madam. Thank you. So I will go through the story of this child. Sorry, the slides are not moving.
You have to stop share and reshare again. Now, just try.
It's still not moving.
Yeah, still not moving.
Okay.
Now, okay.
Yes. So this is a 10-year-old girl who presented with abdominal pain for 1 year duration. I would like you to ask that what would you like to know about the in the history and examination of this child? Is there anything you would like to know about this child?
Sandamali, did she have it during, every day during the past 1 year, and how was she before that?
She was apparently well 1 year back. Then she started this abdominal pain. It was a kind of episodic abdominal pain.
Sandamali, where is the pain actually? Is it?
It was actually mainly in the epigastric and the central abdominal area.
Any aggravating or relieving factors, Sandamali?
There has been, I will go through the history, I think, that there's this aggravating with eating, and it was sometimes relieved with paracetamol, like simple analgesics, and most of the time it would settle on its own also. I will go through the story. This the child's pain started like 1 year back gradually, and now the pain the child had presented because the pain has worsened over the past 2 to 3 months. This pain initially was like 2 or 3 times per month, like episodes. But during the last 2 months, it had been almost daily. That each episode of pain could vary from like 2 to 3 hours or 2 to 3 days. With this, each and most of the episodes, the mother would take the child to a doctor, and she would be given some medications, mainly antacids and proton pump inhibitors, and the pain would settle for a few days, but it would come again. And there were symptoms free times as well. For like some months she didn't get the pain, and during these periods the child was well and functioning. And she has had some admissions also in the past, and she was thoroughly investigated to find the cause of the pain. And about this pain characters, it was mainly located in the upper and central abdomen, but recently this current admission, the pain was mainly in the lower abdomen, but she would tell about the upper abdominal pain as well. And this pain started gradually, and it would persist for a few hours, but it would fluctuate during the hours as well. This pain, the child described as a cramping like or constricting type of a pain, but no radiation and no specific time also with this pain. It has been sometimes come in even in night. And during these periods, she would ask mother to stroke the tummy, or she would sleep or will be crying in the pain. And this pain severity was between like 6 to 7 or to 8 to 9 also, but according to the child, that pain was associated mainly with the severe like loss of appetite. During this episode she would not mostly eat, but this pain may be associated with nausea and vomiting. And also, like almost all these episodes, she was complaining about a headache. And this pain exacerbate with the eating, so she would refuse the food, but it was not associated with drinking water. That pain was as I told, that pain would improve with the medication given by the doctors, but only for a short time, and it would settle its own, and then she will be okay for a period, and then the pain will come again. Then this pain episodes, the recent pain episodes were not responded to usual these antacids and the proton pump inhibitors or simple analgesics. So this other associations with this pain is that headache. This headache was mainly in the frontal area, and it was in a severity of 5 to 6 on a scale of 1 to 10. And child would be irritable during these headaches and scold the parents and others. And but and she could sleep through this pain, and this then upon the waking, that pain has disappeared. No other specific triggers has identified for this headache, such as this stress or sleep deprivation, going out in the sun, and no photophobia like symptoms, and no aura also. She did not describe any aura. And this that about the recent pain, it was mainly in the lower abdominal area, and it would worsen with the movements. So, and is sometimes relieved with the lying down position. And other systems, that she had good bowel motions usually, but like 1 year back she has been investigated for a constipation episode, but after that she did not have any symptoms, and no pain associated with the defecation, and this pain did not settle with the defecations, and no blood, other bile in the vomiters, and no urinary symptoms like dysuria, during this episode, and no fever or diarrhea, and no autonomic symptoms such as fainting, sweating, and no GORD symptoms like flatulence, regurgitation, reflux, night cough, or early satiety. Only the pain with eating, and she gets a good night's sleep, no insomnias or hypersomnias. So this, other than this issue, she has been diagnosed with the mild persistent bronchial asthma during last year, and she's now on inhalers, and she's on well-controlled state of this asthma. And like this, she has had several admissions, and more than admission, she has had gone to several doctors, and most of the time she has been given with this GORD medications, treated as GORD. It would settle initially with these medications, but later it did not. And like this, she has had several admissions during this last 1 year. And this past surgical, she had she had one episode of constipation where she had also underwent X-ray, found to have fecal loading in the X-ray, and one cellulitis diagnosis, and no allergies according to the history. And she has also not given any medications other than paracetamol for this pain by the parents, except this the doctor prescribed medications. And there's no family history of migraine or asthma, and also no other gastrointestinal diseases or other psychiatric diseases in the family. And she has had an uneventful birth and childhood, and no complications. She has a good weight and height parameters, and no faltering of growth during this illness, although she has explained this appetite loss. And development also no significance. She has no developmental delays. Immunization was also up to date. And diet was, she has 4 main meals per day, which contains adequate proteins. She doesn't eat much green leaves, but green vegetables, she get adequate amount of vegetables, and she does not frequently eat fast foods. And specifically, this pain is not specifically associated with any food items, and also not associated with any dairy foods. And this was the second the daughter of the family, and she had a 4-year-old brother. Mother is a housewife, and father works in the electricity board, and he has recently moved to Ampara and comes only in weekends. The father's parents lives with the child, and child is not bothered by the fact that father is not coming home frequently. She likes to attend to the school, and she participates in other sports, and also she has good friends. And mother is the one who takes her to the schools and to the classes and bring her back. She has good academic performances despite the illness, and except this recent admissions for the last 1 month. Other than the last 1 year, she has had good performance, and she's going to face the scholarship exam, and her scores has also increased. And the mother is worried because this abdominal pain is not settled with the medications, and she's now thinking whether it's a serious illness and want to know the cause of this pain. About the asthma triggers, there were some dusty road. Other than that, no specific triggers I could find in the history. So this was the history. Anything else would you like to know in the history? Well,
Can you
yes.
Can you describe her current bowel habits?
She has a once daily good bowel motions. It in Bristol stool chart 3-4 like types, and she doesn't have a constipation. Yes.
She had one episode of constipation,
in the past, yes.
But thereafter, no significant history.
No significant history during even the admission. Yes, she had good motions. Yes, almost daily bowel open.
Sandamali, what about her growth? Is there a growth faltering? Any weight loss like that?
No growth faltering, no weight loss. She has had normal weight gain, no significant weight changes during this 1 year. Despite this,
has she been investigated for anything else like any blood disorders, or is she having any pica symptoms?
No, actually she's not investigated about the other the blood disorders. She didn't have any symptoms of nutritional deficiencies or any signs of nutritional deficiencies. I will go to the examination.
Andamali?
Yes, madam.
Yeah, I would like to know, but it's a good point that even Tharindra highlighted. As you mentioned, she is having some sort of abdominal pain with meals, right?
Yes.
And it's been there for some time, right?
Yes.
So if there's a pain, is she taking food or she's not taking food? That's one question. The second question is there any particular type of food she gets this pain, or whatever the food? So these are the two things, because like if she has pain while taking food or whatever, and then there should be some sort of like the amount she takes would be like maybe reduced. With that reduction, as Tarinda highlighted, it could be some sort of a weight loss. So it's better to like sort of give that statement whether she, despite pain, she continues to like eating or any specific food. I think these two questions, like there. Anyway, could you please proceed with the examination findings?
Yes, madam. During this pain, she doesn't like to eat, but after she comes out of this pain, she eats usually, as usual. So she didn't have any significant weight loss. She is average that built according to the age girl, and no faltering in her CHDR. And other thing is, no, we couldn't find any specific food items associated with this pain. Also, in the examination, she was febrile and no features of nutritional deficiencies, no eczemas, and also she didn't have any features of child abuse. On the examination time, she was in mild pain, and she had one pubertal stage. Respiratory wise, she was that examination not significant, and cardiovascular as well. Abdominal examination, there was mild tenderness in the epigastric area, but no guarding, no rigidity. Also, no organomegaly or masses of fluid, no flank tenderness or palatable masses. And per rectal examination also, there were no hard stools. There were stools, but not hard, and no other abnormalities in genitals to be found. And also cranial central nervous system examination also not significant. And
Pulse and blood pressure is within the normal range.
yes, madam.
Over the hydration?
Hydration was also normal, madam.
Okay,
not
thank you.
Yes.
Dr. Sandamali, whether there is any, I just want to know whether there is any history of, family history of migraine. And the other thing
No.
is, no,
Yes.
no, it's okay. Other thing is, I would like to know whether she is having any discomfort on swallowing and whether there are any other features of atopic apart from asthma.
No, there were no other features of asthma like allergic rhinitis, and there were no eczemas. She had only this asthma. She has had one episode of asthma, and after that she has started on the inhalers. Now she is out of the symptoms with well control. Actually, I can't move the slides. I'm sorry. I trying to. Okay. So.
Dr. Sandamali, may I disturb you?
Yes.
One more question about the history.
Yes.
Yeah. In a 10-year-old child, I would like to know about her tuition classes and also maternal expectations about the scholarship.
I asked about that. The mother was not that mother was not pressuring her for the scholarship scores, and she had one or two classes. She is not pressurized with this academic things.
Okay.
And she's very very enthusiastic and keen girl who like to go to school, and she likes to do the academic things. And
Okay, thank you.
Investigations wise, what are the things you would like to know? There are some investigations I will go through, otherwise it will be that basic full blood count and sorry, and CRP was done, ESR, and also urine full report was done, and stool full report was also not, there were no abnormality, and other liver and kidney was screened for any diseases, and it was like this. The calcium level was also normal, no hyperalbuminemia. RBS also within the normal range. And ultrasound abdomen and KUB has been done several times. Every time it has been normal. The serum amylase was also done 3 or 4 times. The results were like less than 100, and ECG was done, no abnormality, and she has recently underwent upper GI endoscopy also. It was a normal study up to the duodenum, and fecal calprotectin and lactoferrin also done, and it was negative. And stool focal blood was also done once, and it was negative. And these were the investigation available with her. And so this child was, in the summary, was a non-consanguineous marriage, the product of a non-consanguineous marriage without any adverse perinatal events, and with normal growth and development. Now they're having chronic and recurrent abdominal pain for this 1 year duration, and that was initially in the epigastric area, but for the last 2 to 3 weeks she is telling about the lower abdominal area as well. Pain was associated with the frontal headache and nausea and anorexia, and sometimes vomiting. Vomiting was only in this last this admission she had several vomiting. Previously, she only had nausea, and epigastric pain was worsened with the eating. Then examination and investigation were unremarkable, except this mild tenderness in the epigastric area. So I would like to ask differential diagnosis you would consider in this child.
First thing that came to my mind was abdominal migraine because of the headache associated with the abdominal pain.
Yes.
And even functional dyspepsia can be another differential diagnosis.
Yes.
Another thing came to my mind, that's why I asked about the atopy, that it's not that common, but eosinophilic T esophagitis can also cause this long-term epigastric pain in children, but headache won't be there anyway.
Yes, thank you.
Trichophagia DD.
Sorry?
Trichophagia.
Trichophagia.
With this long history and almost all normal investigation findings, I think abdominal migraine is the first DD. Actually, with this history and investigation findings, I think she meet all the wrong 4 criteria for abdominal migraine.
Yes, thank you. Now I will now because with this history we have to consider red flags, and she didn't have these red flags, but I would like to tell those in this kind of a history. The weight loss, involuntary weight loss, and the difficulty swallowing, dysphagia, odynophagia, and as Dr. Sindhupati said, that eosinophilic esophagitis, and this there are some differentials we would like to consider, and significant vomiting, and chronic severe diarrhea she didn't have. Any unexplained fever also, there were no history of fever, no urinary symptoms, and there were no back pains as well. So there are these IBD, celiac disease, malignancy, like these organic disorders we would like to consider if we have these red flags in our history. And other things is in this family history of IBD, celiac disease, peptic ulcer disease, the bloody diarrhea, melena, skin changes, and family history of IBD, celiac disease. Sorry, it's repeated. And in examination, any change in her growth would alarm us, but she didn't have, or up the ulcers, and right upper quadrant tenderness would we would have to suspect hepatobiliary diseases, gallstones, and bile duct diseases, and right lower quadrant pain would we would have to consider gynecological differentials, ovarian cyst, masses, or chronic appendicitis, or left lower quadrant pain, that we would like to think constipation, and also ovary and ulcerative colitis, IBD, suprapubic tenderness, urinary tract infections, hepatomegaly, if there's hepatomegaly, like chronic hepatitis, or storage diseases, hepatobiliary diseases, and splenomegaly, hemolytic diseases, splenic infarct, splenic abscesses, and pyelonephritis, and perianal abnormalities, we would have to consider IBD as a differential. So she didn't have these red flags in her history or examination. So this chronic abdominal pain is usually can be organic or functional. It have to be that the pain persists for more than 2 months, and it is a common presentation in children, and in a prevalence with high prevalence in the age of 4 to 6 years and early adolescent. And with the organs in the each high quadrant at the epigastric and central abdominal area, we would like to consider the organs like esophagus, stomach, duodenum, gallbladder, liver, pancreas, and aorta. These are the organs and the previously called conditions. And so as organic causes like acid peptic disorders, reflux, esophagitis, gastritis, duodenal ulcers, Helicobacter pylori infection, they would get symptoms like this early morning headache and awakening night pain and early satiety, nausea, burping, and occult blood in stool. And pain would mostly be localized to the epigastric and upper abdomen. If there's lactose intolerance or malabsorption, they would get this crampy pain, diarrhea, bloating, intestinal gas related to ingestion of the foods containing these products. And pain will also be there in periumbilical or lower abdominal area as well. If one differential is celiac disease, that they would get crampy non-specific abdominal pain with chronic diarrhea, anorexia, abdominal distension, weight, usually weight loss, malnutrition, and steatorrhea, flatulence, and other nutritional deficiencies. And constipation also a differential. So usually left-sided abdominal pain. Dysmenorrhea, this child is prepubertal, but in a adolescent child, it's also a differential. And this endometriosis was severe progressive. If there is severe progressive dysmenorrhea, the endometriosis will also be a differential, and eosinophilic esophagitis. And then food allergy, if they have associated this other allergic features, and we have to think about food allergy and the inflammatory bowel disease. Also, we know the peripheral stigmata and diarrhea with the bloody stool. And PID also, though rare in pediatric population, we have to consider as a differential. There has been cases. So this about the functional abdominal pain, it will be mostly ill-defined, poorly localized periumbilical pain. That pain will last for usually less than 1 hour and spontaneous resolution, and sometimes associated with autonomic features. They can be triggered, exacerbated like other emotional factors, and child is well and function normally between episodes. And functional abdominal pain disorders are considered, these are resulting from an abnormal interaction between the gut and the brain. So they will they are the more common cause of the chronic abdominal pain in children and also adolescents. This family history will be positive for this irritable bowel syndrome, reflux, and constipation, and they will lack this alarm symptoms. So this child is more towards that. And these are the Rome defined diseases in the functional abdominal pain disorders, that functional dyspepsia, irritable bowel syndrome, then abdominal migraine, and functional constipation and functional abdominal pain not otherwise specified. So in the functional dyspepsia, the pain and discomfort will be centered to the epigastric region. It will be characterized by fullness, satiety, bloating, nausea, retching, and vomiting like symptoms. And it will be exacerbated by eating. And this dyspepsia is actually a differential diagnosis for this child's symptoms. And to diagnose it, we have to have at least 4 days per month for at least 2 months symptoms of this postprandial fullness and early satiety and epigastric pain or burning, so not associated with the defecation. And that this condition could not be fully explained by other medical condition as well. So there are 2 subtypes, postprandial distress syndrome and epigastric pain syndrome. Where in postprandial distress syndrome, it will have postprandial fullness and early satiety, which prevent finishing the meal. And other features are this bloating, nausea, and bridging. And epigastric pain syndrome will we will have pain or burning pain in the epigastrium, and this pain is not localized or generalized, and not relieved by defecation or passage of the platters. And other criteria can include burning quality of the pain, but without retrosternal component, and commonly induced or relieved by ingestion of a meal, but may occur while fasting. And other functional abdominal pain is irritable bowel syndrome, and in children also it's seen, and but mainly in the kind of with adult children. And chronic abdominal pain and altered bowel habits are there, and no other alarming findings. They will have this altered bowel habits and abdominal pain. And this may be preceded by a history of constipation and also an episode of gastroenteritis. And they will have a lowered rectal pain threshold response to the meal. So to diagnose that, we will have to have at least 4 days per month for 2 months symptoms of one of the more of the following. That pain should be related to defecation, and there should be change in frequency of the stool and change in the form of the stool. And children with abdominal pain and constipation, pain does not resolve with resolution of the constipation, like in this child. And that it should be at least for 2 months duration to diagnose. And in the Bristol stool chart, that type 1 and 2 are constipated, and 3 to 5 are in normal, and 6, 7 are in the diarrhea. So with this, that inflammatory irritable bowel syndrome, are subcategorized. So abdominal migraine is other differential, and it is characterized by recurrent episodes of pain for at least 6 months, and the pain should be typically in the midline or poorly localized, dull, moderate and or severe pain, and pain associated with at least 2 additional features like anorexia, nausea, vomiting, headache, photophobia, and fallow. And family history of migraine is also common, so that these episodes should be this at least 2 and this must include all the following occurring at least twice: paroxysmal episodes of intense acute periumbilical midline diffuse abdominal pain lasting 1 hour or more. Episodes are separated by weeks to month. Pain is incapacitating and interfere with normal activities. Stereotypical pattern and symptoms in the individual patient, and the pain associated with the following: 2 or more of the following: anorexia, nausea, vomiting, headache, photophobia, fallow. After appropriate evaluation, symptoms cannot be fully explained by the medical condition. These are the criteria given in the row. So the other thing is the functional abdominal pain, not otherwise specified. It is when these are not included in the other functional abdominal pain syndromes, and episodic and continuous pain, not occurring due to eating, not associated with physiological events like eating, menstruation, and insufficient criteria to categorize into other categories. And also after appropriate evaluation, this pain could not be fully explained by other medical conditions, and this symptom should be present for at least 2 months. The other thing is functional constipation. It's also at least once per week for minimum of 1 month with the following, and the 2 or fewer defecations per week in a child toilet trained, at least 1 episode of fecal incontinence per week, and history of retentive posturing or excessive volitional stool retention, and history of painful or hard bowel movements, presence of a large fecal mass in the rectum, and history of large diameter stools which can obstruct even the toilet. And after inappropriate evaluation, symptoms cannot be fully explained by another medical condition. In the management of these functional abdominal pain disorders, that we have to educate the patient and the parent, because that they should be educated that these are common, and they should be reassured that this pain is real, and that this pain can be triggered by even as the other pains. It can be triggered and exacerbated by the environmental factors and psychosocial factors, stress, anxiety, and other social reinforcement like attention, like kind of things. And this pain is not life-threatening and does not require that activity restriction, and treatment focuses on rehabilitation and return to normal activity despite discomfort. So we have to educate the patients and parents on this, and that there are some dietary modifications we can do, but if only they have this pain associated with these specific foods. That commonly found these food items are like caffeine, chocolate, fried foods, and these gas producing vegetables like beans, broccoli, cabbage, and greasy foods, that high fat food, spicy food, and tomato based products, and other soda, cheese, ice cream, like food. That these children do not have food allergy, and we can advise them to have small frequent meals if they are suspecting to have dyspeptic symptoms. And the one main issue is that school abstinence. So we have to promote them to attend to the school for that. But we should not let them use this nurse's office regularly, because it will reinforce these symptoms, and that regularly sending the child back to the home from the school also will reinforce the symptoms, and that we can give the caregiver when not to send the child to the school, like when they have fever, and that if they are very ill. And other thing is, if they are avoiding school and they are at home, we should not let them have that we should not let them use the television, other entertainment when they stay at home. Otherwise it will reinforce them. And these functional abdominal pain disorders and altered bowel patterns, the children with those, we have to let them use the bathroom as they necessary. And other behavioral modification we could do is that praise or reward her when they attend school or other activities, and identify that and support the child interest and skills outside of the sick role. And also caregiver healthy responses to abdominal pain. That we have to train them some coping skill, but according to the age of the child, some deep breathing or muscle relaxation techniques and distraction techniques and CBT. And if they have symptoms, we can use symptomatic management like probiotics and fibogel and antispasmodic, but they don't recommend in children very much, and also antidepressants only if they met to the diagnostic criteria for the depression. And if dyspepsia, we can have a trial of H2 blocker or PPI for like 4 to 6 weeks, and if there's no improvement, we have to discontinue. And the other metoclopramide, domperidone-like agents are also not routinely used. Cyproheptadine is a kind of a drug which can use for this vomiting in the abdominal migraine and also cyclical vomiting syndrome, and also for the appetite stimulation. So this was what happened to our child. That initially the child was treated enough with this antacid and proton pump inhibitors and H2 blockers, and but pain did not respond, and also she has underwent the upper GI endoscopy. She has also treated with the trial of lactulose and Movicol, and but it also did not settle the pain. So when she came to us, actually, I thought about this abdominal migraine with this history, and he started cyproheptadine for this child. Like for like 2 to 3 weeks we gave, but with that also she did not improve. And we asked the child to maintain a pain diary, and that they had written that everyday like symptoms, and she was not going to school, and she was mother was also a bit kind of distressed because of the daily and increasing symptoms. That she had, the mother of the child has taken her to a psychiatrist during this period, and there she has been started on sertraline and risperidone also as for a childhood depressive episode. Then that time she was on that for like 2 to 3 weeks, but not enough time. But there were no response even. And so we referred the child to the tertiary care for further assessment. That child has had a psychiatric referral, and they have elicited that the child disliked her grandmother. That when mother was inquired, she accepted that the child has expressed her dislike for grandmother several times, but the mother was not that much concerned. That grandmother is the father's mother. She is healthy, but she has kind of a strict personality. That this dislike during the early childhood, she has had a good bond with the grandmother, but when she came to the age of 7, 8, she had noticed that the grandmother, that her new sibling has also come to the story. So she has noticed that the grandmother likes this small kid better, and she has been advised not to play in the house, and not to make it messy, not to make the house messy, dirty, and she has been scolding the child, but not hitting the child, and she has been prohibited like playing inside the house and cluttering these toys and this kind of thing. So she has expressed the mother her dislike. I don't like grandmother. but they haven't bothered about that much. And recently, like last 1 year, that grandmother has advised that child should sleep separately also. That before that she was sleeping with the mother. Now in the same room, that child sleeps with the sleep in a separate bed, and the mother and the other kid is sleeping in a separate bed. And so these things, she has been actually bothered. And her relationship with the grandfather is good, and the grandfather has also been getting angry with the grandmother for this scolding the child. And so but she does not have any anger or this violence toward the brother. So they have elicited this, and then they educated the mother about this psychological aspect, impact on the child's pain. The mother is very educated, and she understood that well, and she was advised for some modifications in the household, behavioral changes. And the grandmother was also taught about the child's status, and she has refused initially that she was not treating her differently, but she has started to change her behavior without scolding and showing the more love towards the child. And she likes dancing, so mother is going to put the child into a dancing class, and also they are planning to go on trips. And for the last 2 weeks, she hasn't complained any pain, and now she is waiting for the psychiatric review in I think in the next week. So this was the case, the patient I came across. These are the references. Hello?
Salma, we can hear you.
Okay. Madam, yeah. So
Salma?
yes.
I have one question. As a child, was it started any anti-migraine medicine like
No, she because she had this asthma also. That cyproheptadine was for this abdominal migraine. That there was we started cyproheptadine as for abdominal migraine, but not any other migraine drugs. Actually, that was the only drug we started. She didn't respond to cyproheptadine.
Yeah, starting like risperidone is antipsychotic, like young child,
Yes.
rather than trying pisodifan and fluorescein is there, so you were great. Like there are a lot of anti-migraine drugs.
Yes, I know that psychiatrist has seen the child and has been started to treating her that notes said that the childhood depressive episode, that she was only on those drugs for 2 weeks duration, and there are no difference of the pain due to with the drugs. Those drugs she is not on any drugs. And she is waiting for this psychiatric review.
And Salma, I forgot to ask about at the history. At the weekend, father is there. What about the symptoms at the weekends?
I did not specifically ask about the symptoms in the weekend. Sorry. No, I didn't actually ask. it is a long history, so that mother also doesn't remember initial episodes. Now for the last 2 months, like she is having this significant pain and significant
Worsening.
yes, worsening.
Yeah, I asked your father went to Ampara, and the start of the abdominal pain is coincident, right? 1 year.
Yes,
What
yes.
now?
That she doesn't bother about the father's presence. She is more attached to the mother. She was not distressed by the father's absence, according to the mother. And I actually didn't specifically ask about the symptoms in the weekend. Sorry, I can ask. I have the contact of the patient. I can ask.
Okay.
Did you find any particular reason for this child to get aggravated symptoms for last few weeks or so?
No, actually, I couldn't find that. I also thought that why this for the last 2 months she's getting more symptoms. Maybe I'm not sure, but no a specific event I couldn't find in the history.
So even with now child is not on any medication, and
Yes.
what about the symptoms?
And symptoms has improved. Now,
Alright.
yes, symptoms now like completely settled. She hasn't complained about this pain for the last 1 week. One week, like she will come again like in 1 week time.
So that means, for whole 1 year or so, this is the first time that child is pain-free for considerable duration.
No, she has had this infrequent episodes previously, but recently she had like several episodes and it was getting worse, and that's why she was referred to the tertiary care center as well. But after that, the talk with the psychiatry doctors, that she has actually improved. Then even without the drug, she has now no symptoms.
So they have omitted those
Yes, those.
antidepressants and all
Yes,
that.
yes.
Okay. So basically, many people have missed the diagnosis and mismanaged life.
Yeah, she was
So
actually
many drugs started, and
pediatric
then
gastroenterologist was mostly seeing her, and that upper GI, and mainly she was seen by the pediatric gastroenterologist. I think for the moment the diagnosis is this functional abdominal pain, but we can see what happens.
Sandamali, did you come across the prevalence in our population, how common it is? And also, is it a risk factor for them to get functional diseases later in life, like irritable bowel, chronic pelvic pain, or other somatoform disorders?
No, I actually found only one article about in our done in our country. I can't remember the prevalence and things. I will see that. I'm sorry.
Thank you.
Madam, there. Madam, are you there?
Yes, I'm here. I'm listening to you all.
Yes, ma'am.
Yeah, there are since there are now other questions, I would like to give some sort of a feedback. First thing is, very comprehensive and very catchy. The first picture with the child, it's very nice. That's how we have to start to get the attention from the audience. It's very nice. And the second thing, while you are like you try to give the information or the sort of like some evidence or whatever about the child, like then and there all the like sort of the other colleagues of you, of course, they ask very good and relevant questions. That's what actually I was waiting for. And like the halfway through, you asked about the differentials, and then the your senior batch, they nicely came with a good sort of the differentials, which is a very sort of more sort of very favorable for this baby. And then ultimately it ended up as functional abdominal pain. Like, do you have any sort of, what are the causes for functional abdominal pain? Do you have any idea?
As described, madam, that this functional dyspepsia and irritable bowel syndrome and functional constipation and those kind of things are considered into this functional abdominal pain disorders, madam.
No, I'm asking what are the causes? Why the person had developed this, like anything, the baby, not the patient, I must say.
It's because, yes, madam, because this due to the interaction between the brain and the gut, that neuronal, that intestinal neuronal interactions, they would perceive the pain. I think due to even for a minor triggers, they would get the pain.
Yeah, so that means the hyperstimulation, of course.
Yes, ma'am.
Yeah, so then why the baby, like any other sort of triggering things for the baby develop this hyperstimulation, like sort of, is it related to, because it's the age group is within the adolescent age group, is it?
Yeah, she's 10 years old, madam.
Yeah, definitely. It's within the adolescent age group, isn't it?
Yes.
And then like 10 years, like it's more towards that adolescence. And then it's sort of like anything like maybe there are dissonance, like cognitive dissonance and all sort of things, which can cause, like, she doesn't know what, like she doesn't understand who am I, like maybe this could be the reason for the hyperstimulation, a lot of things, but those are the things like the several literature says several things, but anyway, but it's a very comprehensive description about all the causes. And then the sort of the support you actually got from your colleagues, it's good. And that is what actually ultimately we want to see from you all, or we to expect from you all. So it's an interaction and your concerns and everything. So this is though it's maybe not, the diagnosis is not correct, but anyway, the way you discuss your scenario with the others, it should be the way, because the differentials could be different. Maybe we do not know sometimes. So one day they will say this is not functional abdominal pain or whatever they think, but still it's good to discuss the possibilities and all sort of things. Anyway, this kind of it's not a complex, but anyway, it'll be you need some sort of a very comprehensive data gathering to come to some actually maybe a diagnosis or the differential diagnosis. This kind of presentations are very useful you all to improve the knowledge and ultimately to become good clinicians one day. Anyway, I thank you very much for the very lovely presentation. As I mentioned last time also, I can remember still you had done a good job during last time.
Thank you
Yeah.
so much.
And Sandamali and it's either the your senior batch, I think they should do more presentations like this, and if they don't have time to go through and better involve and the participation is very important. Maybe this will be 1 hour, 1.5 hours. It's very important them to think what are the things they do not know, what are the things they have to read, or what are the things they want to sort of the brush up the knowledge and everything. So sitting in one place and studying, it's not adequate. So then I think it's good that Desha and Sindupa and all the other people from the senior batch participated. So that's the thing we are expecting from you all. It's good. Anyway, very productive sort of things. It's nice. It's good that we postponed the other meeting. And actually, with that, before you wind up this thing, I would like to tell you all. And I think you will be maybe finishing the current appointments. And then you may be all looking for what will happen to the new stations, and maybe the stations we are there at the moment for the accreditation process. Actually, I wanted to share the real thing regarding the accreditation. Please, Prabhat, once the presentation is over, Sandamali is all the things are over. Please, could you please share the document or whatever the thing I shared with you, the screenshot I shared with you.
Okay.
Could you please do that for me?
Okay, ma'am.
Okay, right. Once she finishes, right? Anyway, thank you very much for our lovely presentation again.